Hey guys, this is Greg McKettrick, and I am the Men's Health Clinical Liaison. And today I'm going to go through the presentation on topical testosterone for men. Here's our safety and disclaimer page you guys can read. Okay, so topical testosterone, what we're going to try and cover in general, just talk a little bit about TRT, and then what is topical testosterone. We'll cover the testing, hormone testing, go over what's available, different types of the topical products, what are the advantages and maybe disadvantages of topical testosterone, do a little briefing on what's available in terms of the commercial products versus the compounded products, and then kind of talk a little bit more about some of the different bases that we are able to use as far as the compounds. So, topical testosterone, obviously, testosterone is the primary male sex hormone. And as we get older, our levels drop. So, it's very important throughout all of our development, from in the womb through puberty and maturation and into adulthood, and is a key factor in terms of proper development uh, throughout the course of our maturation and growth. By age 30, our testosterone levels are actually, they have peaked. And from that point, we're on a downward slide, losing approximately 1% of our natural level of production per year. Now, that is dependent also on lifestyle and other things. Um, Reduction in testosterone obviously leads to physiological changes, um, muscle and skeletal changes, sex drive, has effect on cardiac function, has effect on cognitive function, reproductive. So a lot of different issues that come up as we're starting to see the decline in production with age. Um, and one of the big things that I always emphasize, especially when talking to patients and to prescribers, we talk about the normal testosterone levels and, you know, what is the natural aging process. And unfortunately, we don't really know what normal is for most guys. It might be 1,000 when they're in their mid 20s, and then we tell them that normal is 300 when they're 50. So it's yes, it's part of the aging process, but doesn't really mean that that's normal. So why do we look to TRT? Number one thing is that decline in production and decline in testicular function. Um, it's kind of a natural process. We're all going to go through it. In some cases, we see this as a secondary factor to either a surgery or a physical injury. Um, Overall, there are contributing factors, including pituitary or hypothalamus disease or injuries, um, that can certainly contribute. Alcohol use or opioid use disorder are big factors in testosterone production. One of the things that we battle very, very strongly right now, obesity, especially childhood obesity and diabetes. I have stated in previous presentations that we're starting to see really the effects of obesity causing hypogonadism in much younger populations than what we have seen in the past. And it's got to do with lifestyle, diet, and just kind of how we go about our lives these days. And then there's other things like medications that can affect testosterone levels as well. Um, Studies have linked not only to the obvious like cardiac function and muscle tone and that, but our immune function. And recent studies have shown links to hospitalizations due to, or at least having a factor involved with low testosterone levels. Um, so showing healthy testosterone or patients who are on TRT have a much lower mortality rate, lower hospitalization rates due to COVID-19 as well. The benefits and again, what do we really look to most commonly? Energy, libido, that brain fog, mental acuity, insulin sensitivity, the muscle and bone health. These are kind of your key factors into why we look to TRT. So what's involved? So testosterone replacement is different depending on the patient, depending on their age, depending on what their symptoms are, what their starting points are, what their goals of treatments are. Technically, we see if we have repeat tests showing total testosterone serum levels under 300, that is defined as low T. And again, I repeat this, and I'm sorry for echoing this back and forth, but what really is a normal level? If 300 is called normal, that's really just an insurance number, because the insurance won't pay unless you're below that. But is that really a normal testosterone level? So, prior to initiating any kind of therapy, we have to have a thorough patient examination, including labs, going through the patient's history to really get a good picture of what's going on. And then depending on patient's age and, are they looking to still have children, or have they kind of gotten to a point where they've had all the kids they want and they're not concerned about fertility? We explore different options in terms of boosting testosterone levels. Once we do come to that decision that, yes, we're going to start TRT, then it's to talk about, how are we going to go about this? What mode of therapy? Because obviously we've got a lot of different options. And, here we see you can do the IM injections or sub-Q injections or the pellets. Yes, there's oral therapy, sublingual therapy, or topical, like what we're talking about today. And, for a lot of patients, the topical therapy really is the easiest and the most convenient option for them. So again, once we have decided that we're going to initiate and we've gone through the different methods of testosterone replacement therapy, a lot of patients will come to the conclusion they don't want to do injections. They don't want to go through a procedure to have pellets implanted. So, they kind of fall on the topicals. Obviously, if there was really good therapy using orals or sublinguals, they'd probably go that route, but topical presents typically a better therapeutic outcomes for most patients. So once you've kind of settled on testosterone topical therapy, then what product are you going to use? Which formulation? What's the dose going to be? Have to cover with the patient application sites, and how do you adjust doses and on what timetable? Of a lot of the available products that are commercially out there for testosterone, most of them are quite pricey. So if they don't have that insurance coverage and they're paying out of pocket, they can be kind of a hard sell, just because again, the retail prices on this stuff is pretty high. So why is it that people like the topical testosterone? Well, number one thing, applying a topical testosterone cream or gel or lotion, it's pretty simple. You don't have to know aseptic technique. It's just rub it in. Unlike the injection, doesn't hurt. Again, you don't have to know how to do something using sterile technique. You don't have to be particularly coordinated or have dexterity to do a topical application as opposed to an injection. And dosage wise, the application process, it's pretty easy to measure out a topical dose whereas in some cases, patients have a difficult time even just being able to determine in a syringe what the appropriate dose is. Um, Topical testosterone, one of the advantages that I really see, as opposed to some other methods, whether it be injection or pellets, whatever the case is, daily application tends to promote compliance. People typically, it's pretty easy to remember if, hey, I'm applying this once a day in the morning after I shower. So again, that tends to be a convenient process. There are a lot of trade products out there that patients can choose, creams and gels and solutions. We've had patches in the past. Right now, actually, patches are not so readily available. There's been some issues, and most of the patches have been removed from the market due to some legal challenges to the manufacturers. Another benefit with topical products is, it's really easy to adjust the dose when it's just a matter of how many milliliters of cream or grams of cream am I applying. Typically, timeline wise, once initiating therapy, I generally recommend checking levels again after about 6 weeks. Some doctors will do it as quickly as after 2 weeks, but I think that majority give it a month to 6 weeks before really looking into, do we need to make a dose adjustment? Here's kind of a example of some of the available commercial products. And again, good products, unfortunately, very expensive, but we've got the androgels, testums, Fortesta, Axiron. So very conveniently packaged, mostly in pumps or packets. One thing that I will point out here, and um, tends to be an issue with a lot of patients, is just the concentration of these products. They're conveniently packaged, in a dose size, but that can mean fairly large volume for the patient when they're using this. So, if we're talking about 50 milligram dosage, look at the androgel and the test, and you're talking about 5 grams of product that they're going to apply. So that's a fairly large dosage size for a lot of patients. But again, these vary based on the manufacturer and the concentration. So we'll kind of go through and talk about the differences between some of these and how we relate them to the compounded products. So lots of variety, lots of options. And again, is there a downside to these? Yep, sure. Cost. Cost is my biggest issue. Unless again insurance is covering it, which really they won't touch this stuff typically unless you're consistently under 300 on your total testosterone. Prices for a month's supply on these products easily, and I'm not talking about trade, I'm talking about the generic versions, $350 to $400 a month. The brand versions can go over $1,000 a month. And again, here mentioning the concentration. So, 1 or 2% is typically the most concentrated you're going to see. So a lot of times you're just talking about a large amount of product to apply. That means that you have to have a large surface area. So, you limit the application sites using these trade products because you can't really use a discrete area to apply when you have to apply, 5 to 10 grams. You're talking about a handful. So rubbing it into the shoulders or the shoulder blades or the back of the arms. And again, it's fairly considerable in terms of the volume that you have to use. Um, this is another lead in terms of another, drawback. Big conversation. You get this with a lot of patients and spouses, the transference issue. Uh, so again, larger volume, larger skin area, surface area of application, you have really increase the risk of transference, whether that be to your partner, your children, your grandchildren, your pets, anything. Um, and this is something where, as it's on the skin, you have potential for transference for several hours. And again, this is kind of a factor of the fact that you increase the risk by increasing the surface area involved and the volume of the dose. So the lower the concentration of the product, the greater chance you have. So, why do we like the compounds? Well, it's got all of the benefits of the trade product. It's easy. It's once a day application generally. Um, but the benefits are that we can really customize this. So whereas we're talking about these concentrations of the trade products, very very low concentrations, and we can easily make the compounded testosterone creams and gels, anywhere from 25, 50, 100, 200 milligrams per milliliter. And when you start talking about total dose and reducing that dose volume using 1/10 the volume, that can be a huge benefit. Um, so again, being able to deliver the same dose with a fraction of the volume, that indicates being able to use as much smaller surface area of skin, so more discrete application sites, and again, it really boosts the ability to reduce the risk of transference. Um, we have lots of options as far as the bases with the compounded products, whereas with trade products, it is pretty much, you know, you take it or leave it. So the difference with the bases, that means that you've got creams and ointments and gels and lotions. This is a benefit because if a patient has a particular sensitivity to a base, we can switch that, uh, and we do see that. I see it considerably with patients. And again, different bases do have different absorption properties, going from gels to creams to lotions. So, the rate of absorption, completion of absorption, that sort of thing. But again, there's cost factors there too. Here's kind of a listing of some of the different bases that we commonly see. Probably most common is the HRT creams, and you'll see lipoderms and VersaBase for different applications, or hydrogels. So lots of options, and it allows us to, again, kind of tailor this to the individual patient. One of my favorites is Atrivas gel from PCCA. Um, why is this good? Well, it's formulated without alcohol, so you don't evaporate off. It doesn't dry on the skin. It really pushes the drug through the skin. Um, it's a quick release, more complete, more rapid absorption. Um, and again, this allows for really better overall response. Um, some of the numbers with this are pretty phenomenal, and I've seen it in practice. Um, Actually, we've done testing with this in clinic situations where we're treating a lot of the men's clinics, comparing HRT with the Atrivas, and then following it up with lab tests showing much higher uh, concentrations in the body following the use of the Atrivas versus a HRT cream. Um, so, what does that mean? It means that, you can actually get by with smaller doses than you typically would. Again, what are the benefits? Well, there's cost, there's lower risk of transference, lots of things. Um, Atrevus is more expensive, but again, when you look at it in terms of the benefits and the fact that you can get by with smaller doses and all the rest, it really it's more effective. Another neat thing about it, um, when this was developed, it was tested over like 2,500 patients, and it was proven to be hypoallergenic. Now, I'm not saying that nobody has any kind of a dermatological response to this. Um, PCCA will tell you that they had zero incidents. In reality and in practice, it's really difficult to know for sure, because is it a base that's causing the problem, or is it testosterone dermatitis? But we have seen where patients will react to Adrevis where they don't to a different base. So it's enough evidence there that yes, it's very low rate in terms of causing any kind of allergic or dermatological response, but it's not impossible. So good, not perfect. And here again, the neat thing about the compounds, as opposed to a packet or a tube or a pump, we use the Topical type containers, which allows us to really kind of modify the dose. So again, like I mentioned, if we do 200 milligrams per ml and you want a 100 milligram dose, well, it's 2 clicks. Um, the nice thing about these is, especially when you're trying to reduce contact or transference, you can actually use the top of the applicator to rub it in. So you're not having to use the hands necessarily. Most guys still do, but again, it's one of the benefits to this, and allows for very easy dose adjustments, going from 1 click, 2 click, 3 clicks, 4 clicks, based on what the lab tests show. So it's convenient for prescribers and patients as far as that's concerned. There are alternatives to this. Um, we do have the ability to use the big pump, which instead of a 1/4 ml per click, it's a 1/2 ml per click. We don't use it very often because, again, with most of these products with the compounds for testosterone, we can get that dose whittled down to where it's pretty simple using just that topical. 1/2 ml is usually a pretty easy target, um, using the 2 clicks. But we do have the ability to go into the larger volume, and it does come into play. Not as much for the micro topical delivery for men anyway. For testosterone, for women, absolutely. We just don't see much use of the micropen delivering 0.05 ml per click for TRT for men. But it's available. It's there. So it's always a good option. So application sites, again, kind of mentioned this before talking about the trade products, using the shoulders or the back of the arms, because you need a lot of surface area, a lot of open skin. The good thing about the compounded products, because of the lower dose volumes, we do have the ability to use a lot of more of a varied application sites. We can rotate sites. So from a patient direction standpoint, you would apply to clean, dry, unbroken or intact skin. Typically just recommend get up. If you get this question all the time, get up, shower, and apply. Well, what if I exercise in the morning? Okay, well, you're probably not showering before you exercise. So exercise, shower, dry up, apply. Anyway, it's really pretty simple process, and it's easy to fit it into most people's daily schedules or routine, so you can maintain good compliance. Um, you can kind of see the different areas of the body: upper inner thighs, upper inner arms, abdomen. Certainly the back and the shoulders are good. But again, the nice thing is you can kind of rotate these sites. The main thing is you want that good clean skin so that you get good absorption through the dermal layers. There is a lot of talk and a lot of doctors will advise applying directly to the scrotum. It's very rapidly absorbed. Does not actually follow the typical FDA guidance on this. Um, the reason a lot of doctors do this, number one, is for the faster absorption. They have, in general, some greater impact in terms of erectile function because of that, and because most of the problem with aromatization in terms of testosterone being converted into estrogen or DHT, most of that occurs in fatty tissue, and there's not a lot of fatty tissue in the scrotum, so it can help to reduce some of the aromatization factors. But again, not typically going to be something you're recommending. In practice, it happens a lot, but it's really not. If you're following like the trade products of that, you're never going to see that as a recommended route of application. And we talked about hormone testing. So obviously, before you're starting this, you are absolutely going to get some baselines to see where you're at. Um, and again, I always say, don't just treat numbers, treat the patient, but we have to justify this. We've got to have the hormone testing ahead of time. One thing that is important, a lot of doctors rely strictly on serum testing. And in particular, the topical products, that's not always the best. Really, it's not the best. Because in the bloodstream, the hormones are bound to the proteins, and they don't really get into the tissue where we need them. So we typically are going to recommend using saliva testing for the topical product, because you're really getting the the bioavailable product that's affecting the tissue. And this is going to allow for really better assessment of what's going on in the body and how it's going to affect the patient. And the other nice thing is patients can do this at home. You don't have to go in and have a blood draw, make an appointment at the lab. You can do this discreetly. And of course, you need to make sure that they understand timing and wise. We typically recommend at least 12 hours after a dose to do a test, anywhere from 12 to 24 hours from the last dose. And talking about dosing. So, again, I'm a big advocate with all therapies. Start low, go slow. I've always followed that guideline. So, what do we look for? Well, we want to see patients feel good. And, a lot of patients, again, we talked about in their late 20s, their testosterone level could have been 900 or 1,000, and they felt good. Well, then their doctor tells them that they're normal because they're 301. And let's face it, that's really and truly probably not where anybody's going to feel good. So our target dosage, our target levels are probably going to be in that 500 to 1,000 range. That being said, if you look at the commercial products, most of the commercial products, their recommended starting doses range from 40 to 60 milligrams a day. And that's how they're packaged. Some as low as 25, but generally speaking, 40 to 60 milligrams a day is where they start. And I think that for the compounded, starting patients about 50 milligrams a day is really a good spot. I mean, unless they're severely low and you're trying to get a rapid jump. But using 50 milligrams a day correlates to injecting about 100 milligrams of test sip a week. So again, kind of a good starting point. And then, like I said before, typically 6 weeks, 4 to 6 weeks afterwards, check the level, see where you're at, and then you can make any dose adjustment that's necessary. So a lot of good products, a lot of great things with the compounds. Um, Love the fact that we've got lots of choices of bases. We can kind of again cater to the needs and the preferences of the patients. Obviously, hey, if they got insurance coverage and they're getting the trade products, great. If not, we've got a lot of really nice ways of treating them in terms of the compounds. Um, and there's a lot of options and a lot of benefits to the topical products. It's convenient, um, it's very effective, non-invasive, so patients like it, and it's something that we can work with easily for them. Um, Even with the testing, the hormone testing, saliva testing, it's patient friendly, it's compliant friendly. Um, so again, this is a nice way of helping your patients. But coming soon, we hope. Um, One of the things that we're actively working on uh, is the development of nanotechnology. So, you know, what a huge difference this could make if we can get to the point where we have bases and the process with homogenizers to be able to use nanotechnology in use of these topical products. I mean, just phenomenal. Talk about more effective, more efficient, really reducing dose volume. Um, Again, it's exciting to think what we may have coming really pretty soon down the pike here. Um, so, we're waiting on our folks to do more testing and get to the point where we can implement nanotechnology in the near future. So keep you posted as that happens. Here's a list of references. Tried to cite as complete as possible. And thank you so much. I appreciate your time, and I look forward to talking to you next month. Hope you got something out of this. Bye.